Okay, we are live. Good afternoon, everyone. Today's session is going to be really helpful, and it's led by Dr. Harish from Apollo Cradle and Children's Hospital. He's going to talk about jaundice in newborn babies. So stick around until the end and ask us questions if you have any. Doctor, you have the stage.
Hi everyone, I am Dr. Harish, Senior Consultant, Apollo Cradle Hospital, Kurmangla. So today we are going to discuss about the common problem that we encounter in newborn babies, that is jaundice, or medically we call it as neonatal hyperbilirubinemia. So basically, what is jaundice? Jaundice is it is the appearance of yellow discoloration of the skin and the sclera, which generally the many of the patients see after 24 hours, the baby's skin turns into yellow. So that's what we call as jaundice. But if we have to say medically, it is hyperbilirubinemia. So what is this hyperbilirubinemia? That is increase in the bilirubin. Okay. So what is this bilirubin? Basically, I'll go into how it produces and how it is production, what makes the jaundice to be appeared in the baby. So we discuss about this bilirubin part. So basically, normally when the baby comes out of the mother, so the RBCs, the red blood cells, what we say, which will be there in the baby's what we in the mother is called as fetal RBCs, which have a short lifespan. That means it can have up to a 60 to 90 days of lifespan. So once the baby comes out of the mother, these fetal RBCs will start to reduce by hemolyzing. That means it is getting destroyed, and the more and more hemoglobin is released into the blood, which finally metabolized to what we call as bilirubin. That's why the normally in physiology also the baby's bilirubin will go up compared to the other individuals. But there are certain levels where we take into consideration where the bilirubin considered to be physiological or pathological. We have a chart which we will take into consideration before labeling that baby is having a normal jaundice or it is kind of pathological jaundice. So when I say what are the other reasons which can cause jaundice is the most common physiological causes for the jaundice will be, so sometimes there will be blood group incompatibility. What do you mean by that? There is a negative blood group in the mother, that is called as RH incompatibility. The negative blood group in a mother and the positive blood group in a mother can leads to jaundice. So this kind of jaundice is a kind of pathological jaundice where the jaundice appears within 24 hours. So normally the physiologically the jaundice appears after 24 hours and it peaks around 3 to 4 days, and most of the times in term babies it will come down by around 7 to 10 days. Sometimes it can take up to 2 weeks. So if you take overall out of 10 babies, okay, so in term babies they can have up to 6 babies can have up to jaundice. That is around 60% of the term babies can have this jaundice, and in preterm the incidences will be much higher. So if I go into the blood group changes, blood group incompatibilities, the first as discussed is RH incompatibility, where the mother's is negative and the baby is positive, can lead to jaundice in a baby, and which can present very early also, which can present within 24 hours. So the other blood group changes will be, suppose the mother is O positive and the baby is either A or B. So why it happens is basically because of the ready-made immunoglobulins, that the antibodies which has produced in the mother will go and destroy the RBCs in the baby. That leads to this jaundice. The incidence will be much higher if the previous child is had jaundice. That is, the second baby chances will be much higher compared to the first baby. So basically, this is the common causes which leads to the jaundice in newborns, the OA or OB setting or RH negative setting, which we say in newborns. The second cause why the bilirubin increases will be the to basically because of the dehydration. So dehydration means there is a excessive weight loss in the babies. That is because of the common factors like faulty feeding from the mother, or else any medical issues in the mother which make them stop breastfeeding, okay, or else there is a nipple issues or the improper latching between the baby and the mother. That all leads to the poor feeding in the baby. So that leads to excessive loss of weight. So when this excessive loss of weight happens, so this can cause dehydration. The dehydration in turn increases the lysis of RBC. That means your red blood cells will be lysed further, and which will leads to increased load of bilirubin, sorry, hemoglobin that will inadequately metabolize to bilirubin. So this leads to the jaundice in the baby. So the most this is the common cause that we see in day-to-day practices, like because of the especially the primary mothers where the feeding initiation is sometimes not that great. In those babies we will see this kind of jaundice. So these are the common causes. One is because of the lysis, because of the blood group incompatibility. The second will be because of the poor feeding and all those things. Then comes the third and the other causes will be like sometimes the hypothyroidism, or like the baby having the high TSH values, or the baby have certain metabolic conditions like galactosemias and all. The baby can have during the process of delivery. What happens during, especially during the process of normal delivery, there is the instrumentation which leads to cephalohematoma. That means there is a collection of blood in the head that can leads to slow release of your hemoglobin and then metabolize subsequently to bilirubin. That also causes the baby to have jaundice. So here I am going to discuss only about the unconjugated part of the jaundice, which normally we encounter in all of our babies. I'm not going into the pathological variety of conjugated jaundice also. So basically, how is the bilirubin is excreted? Like why the bilirubin is constantly goes up, and what makes, how to improve the things, and all those things we will discuss in this session. So basically, once the bilirubin metabolized, so basically it will be taken up by the liver. So the thing is, the bilirubin will be is in unconjugated form. This will be taken up by the liver to make it conjugated. That is because if we the conjugation process does not happen, this unconjugated bilirubin is quite toxic. So whenever the bilirubin is metabolized to the conjugated, that it is very easy to excrete either through the urine and stool. So how can the parents know whether my baby's jaundice is increasing or decreasing? So the one factor will be always is clinically. So you see the appearance of the baby. So suppose if the jaundice compared to yesterday, it is much increased, like in the sense, if it is up to the trunk, now it is progressing into the lower limbs, into the hands, or into the legs, palms and soles. That means your baby's jaundice is increasing. So apart from that, you will see the diaper. If as the day goes by, the number of time the baby urinates, the number of time baby stool passes, or the color of the stool should change. If the baby's stool color has not changed, or the baby is still passing green colored potty, or the baby's urine frequency is also not increased, that itself says there is an issue with the feeding that might leads to the persistent jaundice. Okay, so basically, in educative point of view, the parents can look into certain factors that can tell them like whether my baby's jaundice is getting better day by day, or it is the same, or it is increasing. So this happens with those mothers who are feeding is not great initially, but over a course of time, which has increased. Okay, so these are the common ways we can think of it. The second part of jaundice is what we call as pathological, or pathological jaundice, where the rate of rise of bilirubin, which is quite significant. That means like every day the baby's bilirubin is increasing by more than 5 milligrams per deciliter. So the common causes for pathological jaundice will be the baby having RH incompatibility, the baby having hypothyroidism, baby having galactosemia, the other entity what we call as G6PD deficiency, and certain disorders pertaining to the liver also. Okay, so these are the certain basic problems that we encounter during the newborn period, which leads to the persistent of jaundice for longer duration of time. The how do we evaluate, how do we investigate? So basically, we will evaluate by once the baby comes to the hospital. We evaluate by clinical examination to look for any cephalohematoma and all those things, any enlargement in the liver to look for any metabolic disorders and all those things. Then the transcutaneous we will check, which will tell us like what is the current value of the bilirubin. If necessary, we will take the blood and we will get the exact value of the baby, and based on that, the treatment will be initiated. So coming to the treatment part, so we will discuss that basic treatment. There are two basic common treatments we do for the neonatal jaundice will be, the one is phototherapy. So the second is like we give IVIG. Third will be exchange transfusion. These are the common modes of treatment which is available and which we do in our day-to-day practice. What we do is what we call phototherapy. It's an intensive phototherapy. So basically, it's a UV light that we give, blue light, which has a wavelength of around 400 450 watts. So that will help in oxidizing the bilirubin to the, I mean, basically the unconjugated, which is it's not water soluble. To make it soluble, it will be oxidized and then which will be excreted in the urine and stool. So this is what that phototherapy does. So in case of sometimes if it is jaundice is prolonged because of this ABO or RH incompatibility, we give what we call as IVIG. So which will bind to the already formed antibodies in the mother and make that the further lysis of RBCs is reduced, and thereby it reduces the uh, jaundice. So that means the bilirubin will be reduced. The third, in severe cases, what we give is exchange transfusion. So I'll discuss this part. What is the exchange transfusion? Before that, we will discuss what happens if the bilirubin levels are very high. Say there are certain values, as I told before, there are charts that we take care of to plot the bilirubin levels according to the gestation of a child, according to the day of life of a child. So based on that, we will chart. Suppose if the baby's bilirubin is very high, so which is in a zone where we need to do the exchange transfusion, then only we do the exchange transfusion. Otherwise, most of the times the baby's jaundice will be managed through phototherapy alone. So, what are the conditions which how do you make out clinically this requirement of exchange transfusion is basically an entity called bilirubin encephalopathy. That happens when the bilirubin levels are very high. Since this unconjugated bilirubin is can get into the blood brain barrier very easily, so it crosses the blood and enters into the brain and cause so damage. So that basically most of the time happens in your basal ganglia. So this is basal ganglia is basically part of the brain where it goes in and accumulates and causes the certain irreversible damage in the brain. That's why we need to treat the jaundice at the earliest. Otherwise, it presents with a long-standing neurological disability in newborns. So, what are the symptoms of this bilirubin encephalopathy? So, the bilirubin encephalopathy is we again will characterize into three stages: stage one, stage two, stage three. The one which will be initially, they all depends on the refusal of feeds and then the cry of a baby, the tone of the baby. So this will tell us like what is the stage of the baby is initially the cry is very shrill, the baby is having problems, and all those things will tell us whether the child is having which kind of metabolic encephalopathy, the bilirubin encephalopathy. So the treatment for this kind, if it is stage one and all, many of the cases it can be reversible by doing exchange transfusion at the earliest. So what we do in this exchange transfusion, basically we want to clear out this all the bilirubin from the baby. For that we do exchange the blood. We exchange the blood with the same blood group of the baby so that all the bilirubin will be taken out of as early as possible. So this way can lead to sometimes the reversibility of the symptoms that is already started, but still the disability cannot be completely be cured of. The child may be present with the long-term neurological disability. The grade 2, grade 3 and all, the child probably will have a sequelae. That means they will have some long-term neurological disability. So these are the basic things that we will come across when we are discussing with the neonatal jaundice. So the take-home message from this topic will be for the parents is the all babies will not have jaundice. Out of 10, the 6 can have. That means around 60% of the term babies will have, and 80% of the preterm babies will have jaundice. So the risk will be higher if the previously the baby has the jaundice, and the second baby risk will be much higher. Then how to at home, what the parents can do to reduce this is only by increasing the feeds and all those things. Okay, proper feeding will help in reducing the jaundice, especially those there are no underlying risk factors. Then comes the management part. The management wise, there's not much they can do at home. If the baby, you notice the baby's discoloration is increasing day by day, then you need to rush to the hospital to take appropriate care. So there is no evidence or any literature to say sunlight has any benefits in reducing the physiological jaundice. The physiological jaundice generally goes by 7 to 14 days. So the parent should not consider exposing their baby into the sun for longer duration of time just to reduce the jaundice. Thank you. Hey, Bamaria.